The second example I like to use to illustrate implementation research at work is the community-directed intervention against health problems, otherwise called CDI. In this case, the implementation challenge was how to achieve and sustain very high coverage of ivermectin for several years in an area that is endemic with onchocerciasis. Given that onchocerciasis control requires an annual treatment of a total population that is at risk, reaching a very high treatment coverage level for several years, as much as 15 years, is a major challenge to the health system. Experiences had shown that mobile teams had been tried, they had been used to see if such a high coverage could be achieved. Unfortunately, it was too expensive, coverage rate was not satisfactory. Community-based approaches were introduced, yet coverage was less than satisfactory and sustainability issue was a problem. So Tropical Diseases Research Program was asked to study all these community-based approaches and to find the most effective and sustainable method of treatment of large populations over several years. In 1994, TDR launched a two-phase multi-country study. The first phase was formative research. All the community-based approaches that were designed for communities were studied. And the finding was community members were not involved. Community members were mere recipients of the service that was based in the community. Their participation was very little, most often limited to mobilizing members of the community to a central area where the ivermectin drug was distributed by non-governmental organizations or health workers. So they were passive recipients. A finding from this formative phase also showed that communities were capable of organizing themselves around complex activities, sharing resources, and delivering service to members of their community. The findings from this formative phase led to an experimental study of community-directed treatment with ivermectin. The study at this experimental stage compared an approach that is designed by the community itself with another approach that is designed by the program. The findings from the experimental research concluded that community-directed treatment with ivermectin is feasible and effective. It's likely to be sustainable. It can achieve very high coverage. Correct treatment procedures were capable of being complied with by community members. The study drew attention, just like we found in home management, to certain key points. These are flexibility. The importance of flexibility at the community operational level was stressed in the findings. The issue of reporting was also mentioned. You will recall that we discussed during the home management approach the issue of reporting, which was a problem. It was also found that it remained a problem for community distributors to report properly after delivering service to members of their community. Like we found in home management of malaria, community-directed treatment with ivermectin has since evolved, riding on implementation research all the way. In 1996, implementation research showed that community-directed intervention strategy was feasible and effective and likely to be sustained. In 1997, the African Program for Onchocerciasis Control, APOC, adopted it as a main strategy. So the results for the implementation research was grabbed immediately. It came out by APOC. In 1999, treatment coverage with ivermectin using this community-directed treatment with ivermectin approach was noted to be about 2 times higher than conventional method that had always been used by the health system. CDDs, that is the community-directed distributors as the community providers were called, were very much involved in other health interventions, indicating that there was a wide acceptance. So the community-directed distributors at the community level were very much involved in other activities at the community level. The excitement led to APOC to ask TDR to study the use further of CDTI strategy for other interventions with different complexity levels. So we can see how CDTI evolved to the next stage. Community-directed intervention could be used for other interventions of different complexities. The attribute of implementation research to respond to the needs of implementation barriers was clearly demonstrated here. Let's look at community-directed intervention briefly, which is the strategy we're talking about, the intervention that was to be applied. It is a health intervention which is undertaken at the community level under the direction of the community itself. So communities have a role to play, the health system has a role to play. Working together as partners, that's crucial in community-directed intervention. The steps are shown. One thing we should note is that community is not a passive recipient of service, but a central player to the service being given at the community level and a partner to the implementing agency like the health system. In this case of multi-country study on CDI, implementation research was set out to answer the question, how far will the community-directed intervention approach go where there are multiple health issues? The study design in this case takes into consideration the complexity. We look at complexity in 2 ways. There is the complexity of the individual interventions. For example, CDTI and vitamin A are taken as very simple, a single commodity given annually, insecticide-treated bed nets. The bed nets are bulky, and there is also the complexity of utilization, home management of malaria, where individual case management was required. Malaria occurs throughout the year, introducing a different type of complexity. Then, of course, there is dots. In the case of tuberculosis, case detection, referral were complex issues that needed to be looked at as well. Besides the complexity of the individual interventions, there is also the complexity of the number of interventions that could be managed by the community at the same time. Different districts were selected for different intervention pairing, so that at the 3rd year, all the interventions had been added. Typically, as we found in the home management of malaria, and a major element in implementation research is the multidisciplinary team approach, which involves experts from affected countries. You have the epidemiologists, the health economics, social behavioral scientists, statisticians, data managers, as you will see in the picture. For all the interventions, community-directed intervention yielded higher coverage than the current approach, whether it is malaria, where coverage was twice as high as what was obtained, and the insecticide-treated nets, which was twice as high as well. Vitamin A and ivermectin coverage was significantly higher, showing that despite the complexity of the interventions and the fact that there were multiple interventions being put together at the same time, it was still highly effective. Communities, therefore, could handle several interventions at the same time, irrespective of their complexity. This does not apply to DOTS, and for reasons that there were not so many tuberculosis cases in the villages, there is the issue of stigma, there is referral. With respect to efficiency of community-directed intervention, it was highly cost-effective, and the health system did not have to bear all the costs because the cost was spread out to other stakeholders, particularly the community. In order to tease out the critical factors that facilitate and that may hinder community-directed intervention, an elaborate design of a conceptual framework of the CDI process, which guided the social behavioral aspect of our research on key elements of the process, was developed there. Looks very complex and takes into consideration lots of issues from the stakeholder process to the health system dynamics, as well as how communities are engaged, how they are empowered, as well as the engagement of the CADI implementers right up to the broader health system issues. As we found in home management of malaria, one critical facilitating factor for the community-directed intervention, which was reported using the implementation research to tease it out, was the role of the community actors. Communities share the burden of implementation with the health system. So the CDDs took some of the time which hitherto the health system would have shouldered. Shortage of supplies was a hindrance to community-directed intervention. It was reported as such. So, I repeat, it is important that an implementation research identify those factors that we facilitate on one hand, as well as report those factors that we hinder so that they can be addressed, either using another design of implementation research to address them, or getting the health system just to take note and be aware that they are there as hindrances that need to be addressed. An implementation research will make recommendations and share these recommendations with policymakers and implementers. For example, as you will see in this beautiful photograph, the community-directed intervention team, the team that did this research, used various approaches to disseminate the findings. The most important approach is to make presentation to the system, the health system. So policy implementers are always waiting for the results to become available. This was the case in community-directed intervention that I'm talking about. The uptake and the scale-up was immediate. Another advantage of implementation research is that the tools, the manuals, education and communication materials that are used during the implementation research, when refined, become easy to use by the health system, like monitoring tools, like evaluation tools. I will invite you to visit WHO website, download and watch community-directed treatment with ivermectin video. You will like it. In this chapter, describing what implementation research really is, we discuss two approaches to implementation research. The home management studies, which use the sequential implementation research approach, and the multi-country studies, which was done in two phases, the formative and the experimental. Both of them have all the elements of implementation research, which is irrespective of the approach that one uses, whether sequential, like in the case of home management of malaria, or multi-country, like in the case of community-directed intervention. Implementation research is used to resolve hindrances to the use of efficacious interventions against health problems. Thank you very much, and goodbye.